Good morning, everyone. Welcome to our third presentation in our webinar series on the role of inflammation in psychosis. So my name's Danielle Smith, for those of you that don't know me, and I'm one of the research assistants working on the PPIP2 and SINAPPS2 studies. I'll be chairing the first part of the webinar today, and then my colleague Isobel Harrison, who's one of the other research assistants in the team, she will chair the question and answer session. Before I hand over to today's speaker, I'll just briefly outline the webinar format. So we'll have a presentation from Dr. Kabir that will last about 20 minutes, and then we'll have a 10 minutes Q&A session at the end to answer your questions. We've muted all of the attendees just to avoid any background noise and any disruption, but please do use the Zoom chat feature to submit any questions that you might have, and Thomas will answer those at the end. If we don't manage to answer all of your questions during the webinar, we'll put them together in a document for you and get them answered and email them around at a later date. And we'd also just like to remind you that this webinar and all the other webinars in our series are being recorded and will be uploaded to the YouTube channel and on the website. So they can be accessed at a later date, and if you want to forward the link on to any colleagues, you can do that later as well. So without further ado, I'm pleased to introduce today's speaker, Professor Thomas Kabir. So Thomas Kabir is the Head of Public Involvement in Research Programme at the McPin Foundation, which is a charity aiming to transform mental health research by putting the lived experience of people affected by mental health problems at the heart of the research agenda. Dr. Kabir has previously worked as a mental health advocate for Mind in Camden, and with commissioning support for London to support the establishment of improving access to psychological therapies services across London. He also coordinated the National Service User Involvement arm of the NIHR Mental Health Research Network, and he's worked on a number of national public and patient involvement in research initiatives and service user focused outcomes. So Dr. Kabir, if you could start your presentation, I'll hand over to you.
Thank you very much for inviting me. Can I have my slides, please? Isobel, are you okay with starting my slides?
There we go. Louise is doing that one for you. There we go.
Again, thank you for that introduction. My name's Thomas. I'm Head of Public Involvement at the McPin Foundation. In a separate role, I am also chair of a NHS Health Research Authority Research Ethics Committee, but I am speaking here in my McPin capacity. Next slide, please. So I do just need to add a disclaimer that I am neither medically nor legally qualified. Please treat the following presentation for that reason as opinion, not fact. Next slide, please. So I want to cover three main things in this presentation today: the legal basis for consent, specifically in research, mental capacity and research, and I think that's the cause of many disagreements, and handling disagreements with family and friends, as the title of my talk suggests. Next slide, please. So to start with, there are three laws that potentially apply to SINAPPS study participants. There's the 2004 Medicines for Human Use, better known as the Clinical Trials Regulations Act, 2004, and as amended since. That does apply to the SINAPPS study because it's something called the CTIM. There's the Mental Health Act, which will apply if someone is under a section of that act. And then lastly, the Mental Capacity Act 2005, and as amended since, may apply as well. So what I'm trying to do is to set the scene that legally it's complicated. You have three sets of laws which potentially interact with each other, which could apply for people's care rather than their research, or vice versa. It's not easy. And I'm going to speak more about capacity later, as again, I think it's the root of many disagreements and problems that I'll be talking about today. Next slide, please. So I'd like to talk a little bit about the legal basis of consent in research. In common law in general, and this was conceived mostly around people's treatment, of course, in common law, in case law, no one can provide consent on behalf of another. That's the legal common law principle. If someone does lack mental capacity, then the Mental Capacity Act 2005 provides a framework for decisions to be made, and it has provisions under section 30, I believe, and there's one other section specifically for research. Now, in these cases, a consultee, that's the wording that's used, must be consulted, but a consultee does not provide consent. Instead, a decision is made in the best interest of the person concerned, and the consultee essentially provides an opinion, but it is not consent, and it's quite clear that it's not consent. And there's quite a lot of stock in the Mental Capacity Act Code of Practice that this decision should be a best interest decision. Next slide, please. However, this does not apply to the SINAPPS study. For clinical trials of investigational medicinal products, CTIMPs, there is a different piece of legislation, which is the Medicines for Human Use Clinical Trials Regulations, and that slightly preceded the Mental Capacity Act. So we've got two pieces of legislation covering research. In our case, it's the Medicines for Human Use Regulations. In this case, a personal or professional representative's opinion is sought. It could be a clinician, it could be a doctor, or someone else not connected, of course, with the study who provides consent. And this opinion is the presumed will of the person. It's described as consent in the wording of the Act. The representative, whether they be a professional or a legal representative, is the decision maker in this case. They in fact have a fair amount of power, slightly more power, I would say, than under the Mental Capacity Act. And under these regulations, there must be grounds for expecting that administrating the product will produce a benefit to the person that outweighs the risk or produce no risk at all. So I would say actually there's a slightly higher bar to be met for CTIMPs than there is for other research that may lie under the Mental Capacity Act. So what you have actually is two separate pieces of legislation, both covering research, both with different legal frameworks. And it's arguably harder to include someone who lacks capacity in CTIMP research than other kinds of research. In some ways, as I say, the legal representative under the CTIMP regulations has slightly more power, and they actually have the power to remove them from research at a later stage. Next slide, please. For a great discussion of all of this, please do have a look at this paper. I beg you, it's really good. It's written by Victoria Shepherd from the University of Cardiff. It's open access. I put the link down below. And Victoria Shepherd makes the point that people lacking capacity are often excluded from research that is about them and concerns them and is for them. And this produces an evidence-biased medicine. But actually the legislation as it is and as it is enacted is overly paternalistic and can produce research that is rather biased and exclusive. There's little guidance, by the way, under the EU clinical trials regulations about how a decision should be made, how a professional representative should make a decision. It's slightly clearer in the Mental Capacity Act because there's such a great amount of guidance around it. Next slide, please. So as I said earlier, I think mental capacity forms the basis of some disagreements around people's participation in research. The Mental Capacity Act 2005 is quite clear that people are presumed to have capacity until shown otherwise. However, in practice, I think many people working in research and treatment in the NHS generally have the opposite assumption that people actually don't have capacity until shown otherwise. It's very clear that mental capacity is time and specific, decision specific. It's not a one-time thing. If someone lacks mental capacity for one decision at one moment in time, it doesn't mean that they will lack capacity a day or even an hour later. And at the outset, and perhaps I've worded this poorly, given what I've said, it's important to establish if someone really does lack capacity. What I'm trying to get at is that I think there needs to be some quite strong, reasonable evidence that someone lacks capacity. People should not have a test of capacity, in my opinion, unless there's real, sure reasons for doubt before they take part in research. Next slide, please. And more people than you might think actually do have mental capacity to take part in research. So this is a paper which was produced by Dr. Ben Spencer. He is a psychiatrist. He's recently been elected actually as an MP in Parliament. And he conducted a study as part of an NIHR doctoral fellowship, interviewing 84 fairly severely unwell patients with schizophrenia within hospitals in the SLAM Trust. And he concluded that just over half, 51% of people did have capacity to make a decision about whether they wanted to take part in a research project. The dummy research project that was used was an NIHR bioresource study, not too unlike PPIP, from what I can see. And just under a third of people had capacity, that's 41%, had capacity to make decisions relating to their treatment. It's a very interesting paper. One of the first of its kind. Again, it's open access. I've put the link for you to look at below. Next slide, please. So, in my opinion, from seeing all of this work out, informed consent is the result of a process. Information sheets or consent forms are, of course, an important part of the process. It stops telling people's porkies because you've written it down, but they are only a part of this process. I think often the mechanics of research work the other way, that information sheets and consent forms are a major part of that process. But I believe that good conversations are just as important as information sheets and consent forms. Indeed, many forms actually do, consent forms that is, do have a clause saying that I've had the opportunity to ask questions and have them answered, ... And the actual wording of the legislation of the EU clinical trials regulations, by the way, they don't actually specify, these laws don't actually specify what information about a study is provided to people, just that information is given. But the wording of the EU clinical trials regs are quite curious because they also speak of, and I quote, legal representatives being given the opportunity to have an interview. Interview implies a verbal conversation with a member of the investigating team. The word interview is used a few times, which I think does open the door for good conversations. Next slide, please. Many information sheets in studies for people lacking capacity are problematic. And again, the same author of the paper from 2016 produced an excellent paper on all of this in 2019. And again, I beg you to look at it. It's got a really great table showing the differences in consent between research under the Mental Capacity Act and CETIP research, which is covered under the EU clinical trials regulations. And after identifying 1,194 studies and wishing it down to 42 studies, Victoria and others did a content analysis of the information sheets and drew out many, many useful points. Next slide, please. Again, it's open access. I urge you to read it. And I'm just going to read from the screen, but the conclusions are fairly self-explanatory. Despite undergoing ethical review, study documents lacked essential information, incorrectly used terminology, and conflated professionals' clinical and representation roles. Future recommendations include ensuring proxies are provided with adequate and accurate information which complies with legal frameworks. Further research is needed to explore the information and decision-making needs of those acting as consultees and legal representatives. And the point is laboured in that paper that there's little support given to people who need to make decisions, whether they be personal or professional representatives, such as doctors or nurses or whoever they might be. It's quite tricky and quite a hard place to be. And the two pieces of legislation with two legal frameworks around them, with two different sets of practices around them, do not make things any easier. Next slide, please. So that's just to summarise. Given all of this, perhaps it's not surprising that disagreements happen. You have the Mental Capacity Act, which can apply, and does apply indeed, and applies outside of the provisions made for research. You have the EU clinical trials regulations, which simultaneously can apply. And if someone is under a section, the Mental Health Act, can apply as well. It's very complicated. And of course, there are examples of research where there are both CTIM and non-CTIM aspects, and someone lacks capacities, and things get even more complicated. Next slide, please. So moving on to the actual title of the talk, my talk, Handling Disagreements with Families and Friends. I keep coming back to generating as many conversations as you possibly can, making contact with family members and friends as soon as you can, and finding out their wishes and generating as many conversations as you can. On a human level, my experience is also that it comes down to trust. As soon as you can meet people and they can see you face to face, they can make a judgment as to whether they fundamentally trust you. And I think that goes a long way, as well as, of course, answering any questions that people have. It's important to try and work out what the issues actually are. When I was a mental health advocate and I go into inpatient wards or elsewhere, it wasn't always clear. In the case of SINAPPS, there are issues. So people can be put in the control group or the interventional group. And of course, there's the issue of randomization and blinding, that we are not going to know who's going to be put in what group. What we do know, we do have hints of rather, is that people who do take part in research generally do a little bit better than people who don't. The reasons for that may be complicated, but I think they probably have something to do with people being followed up a bit more regularly than they might have been under routine care. And although you cannot say ethically that people will do better if you're taking part in research, I think there's no ethical problem as such, and this is just my opinion, with pointing out that people who take part in research are followed up relatively frequently, and that certainly is the case in SINAPPS. Do try to involve an independent advocate. A good advocate will, again, help speed up the conversations. Their training should help them to identify what the issues are and actually communicate communicate between professional and other groups. That's what their role is. And if someone is detained under the Mental Health Act or they lack capacity, there is a statutory duty for them to be provided with some kind of advocate. The exact nature of that advocacy service will depend on the service provision locally. Again, I'm labouring the point. Do remember that information sheets are just one part of a process that will lead to a decision to participate or not. Whatever local R&D procedures may be, information sheets are not actually named in legislation, either the Mental Capacity Act or the EU Clinical Trials Act, and interviews, in inverted commas, specifically are under the EU Clinical Trials regulations. There is nothing wrong, in my opinion, of having conversations. That's perfectly okay. Some places may take the view that all you need to do is to send off an information sheet and then wait for questions or try to and not have any further communication. I don't think that's necessarily actually the case. And of course, we must and should always respect the wishes of family, friends, and of course, primarily of the research participant themselves. So we should always, regardless of whether they lack capacity or not, seek the views of the person concerned. And the Mental Capacity Act actually puts this rather starkly. There is actually a statement in there that's saying that nothing should be done which appears to contradict the wishes of the person concerned, or if they show that they don't want to take part, even though they're lacking capacity, that wish should be respected. Although that is not actually the case under the EU clinical trials regulations, which apply to CTIMs. Nonetheless, the wishes of the person concerned should always be respected. Just as a side note, CTIM research can get very complicated. That may be the reason for the regulations being worded in the way that they are. I've seen research involving, for example, valves, artificial valves, valve replacement for heart surgery, which include bovine tissues. That's tissue from pigs, which of course may throw up all sorts of issues for people from certain backgrounds. I spoke to a couple of surgeons down the years about this, and he said, well, no one has actually refused to have one of these vows on that basis. But it's an example, I think, of a specific situation where it needs to be flagged up to people, a specific group of people, that there are issues. It does need to be addressed. There does need to be conversation. There does need to be a weighing of risks and benefits. And that requires, again, I come back to the point, good conversations. Next slide, please. News and other stories can be just as helpful as the consent form. Luckily around SINAPPS, there has been a fair amount of good publicity, I would say. There's a picture there from the BBC News of Sarah Galloway telling her story. There is a BBC, I'm not sure if it's still available on iPlayer, I hope it is. There was a short thing on BBC Ideas, that's a short video, and they're a bit more digestible than information sheets, which are a bit long. And there's a list of those on the SINAPPS website, and I've just put a link there. They're a very useful resource in my opinion, and I think they can complement information sheets, consent forms, allowing people to do their own research, and they're quite easily digestible. Next slide, please. At McPin, we've produced a number of materials aimed at the public, both with Sarah Galloway and members of our public and patient involvement group for the study. We've so far produced 2 booklets. I believe that at least one of them is sent out to potential SINAPPS participants, the antibody-mediated psychosis booklet. But both those booklets are in lay language, I hope. Relatively easy to understand, with lots of links for further information, and those are also available on the SINAPPS website. Please do have a look. Next slide, please. So I just want to say thank you for listening. If you've got any questions, of course, we have the Q&A. There's my email address and my Twitter handle. This field is complicated. There's lots of rooms for diverging opinions. The legal framework is complicated, and whilst not completely contradictory, 2 or even 3 laws can apply to the same person at the same time in different contexts for different decisions. It's very complicated, lots of rooms for decisions and lots of room for discussion. Thank you very much.
Brilliant. Thank you, Dr. Kabir. That was really interesting. I'm sure we can all agree that this is a topic that we really need to be thinking about and discussing in much more detail. We'll move on now to a time of Q&A, so just encourage you to put questions into the chat. I know sometimes when we can be watching these, we're concentrating and thinking through everything, so now just give you a moment or two just to write some questions that you might have. I'll hand over to my colleague Isobel just to chair this section of the webinar.
Thank you, Danielle, and thank you very much, Thomas. That was really enlightening and useful. I think gives us some tools, as Danielle said, for including people in research as much as possible. We have a question from Alistair. Would you recommend the use of video or film to provide information on a trial?
Yes, I would. I think it's a lot easier. It's a better format in some ways than the information sheet. Having said that, there is always a place for the information sheet because, again, it comes back to the point, it stops people changing their minds. It does include some information which it would take ages, such as the side effects of an IMP. It contains some legal information, it contains some contact details which must be in there. So I think as part of the informed consent process, absolutely.
Okay, and thanks, Thomas. And a follow-on question, again from Alistair. Do you think it's important to have a documented and systematic way to demonstrate capacity before taking consent in the case of a trial?
Well, no, I don't, because again, coming back to my point, the Mental Capacity Act actually says very clearly that people have capacity until proven otherwise. Though I think it's problematic because we'd go back to testing capacity. And in fact, 2 of the information sheets which Victoria Shepherd looked at in her second study, the 2019 paper, actually built into their consent process a test for capacity, and that's wrong. That's not in keeping with the Mental Capacity Act, which is that people do have capacity. I would only want someone's capacity to be really questioned. I can see the utility of the question, But I would only want someone's capacity questioned if there really was some real significant doubt around that pupil's capacity. And remember that capacity is not about reaching a wise or reasonable decision. It's about the ability to retain information and to make a decision. It does touch on understanding, of course, but it actually isn't the central part of that process.
Excellent, thank you, Thomas. I had a question about utilising an independent advocate, and I understand that people under the Mental Health Act have a statutory provision of one, but where do you recommend otherwise researchers seek out these independent advocates, or kind of where they sit within the NHS structure and their kind of availability?
It very much, I'm afraid this is a very complicated and very much depends on the setup and of course where people are. So if people are inpatients, it's generally very easy. People will know where the advocacy office is. Often they will come onto wards. There will be notices on the ward itself with the number of the advocacy service to call. In the community, it's a bit different. You need to check where people actually are. And in an acute hospital, such as Addenbrooke's, the advocacy service may actually be situated somewhere else entirely. I hope they're situated within the hospital, but your PAL service should be able to direct you. It depends on your services. I'm afraid they're completely different setups. But if you're an inpatient, there should be, you should be directed towards a mental health inpatient, that is. It should already be it should already be publicly available. If not, you might need to check with your PAL service to check where the advocacy service actually is and where the contract lies with. Remember that advocacy can sometimes be provided by a third sector organisation, such as a charity, so they may not actually be on site. But I would recommend that you check and you find out where they are before actually starting a specific research project. But certainly mapping out where they are, because quick access is really, really important. These things happen really, really quickly, and it's important to know where people are. The short answer is, I don't know, depends on the service, but please do find out as soon as you can.
Okay, thank you very much, Thomas. I wonder if we have a couple of minutes left. I wonder if anybody has any more questions for Thomas. I was interested in your information about making information sheets and consent forms kind of easily readable to people who might have difficulties concentrating. And when you're formulating these, do you recommend kind of involving patients and the public in kind of formulating the consent and information sheet?
I would always recommend that. And in my last job with the Clinical Research Network, I actually founded a service called FastR, which was a service to do exactly that. And it still is in existence, but works with studies supported by SLAM and the Maudsley BRC. But I think that's a very, very useful feature, useful thing for people to do, and to run through information sheets and consent forms through any PPI groups that they may have locally. I try to help with them at McPin, of researchers as best I can. But one of the points that's made by Victoria's paper is that the wording in the consent forms and information sheets, the templates which CRS and other organisations require us to have, isn't that helpful. Sometimes it's actually legally just not quite right. So it's important to put quite a lot of effort into it to try and make it as accurate as possible, and to produce easy to read summaries of it for people who, again, as you point out, may have problems concentrating. Many of these documents are very long, very hard to understand.
Mm. Thank you very much, Thomas. That's really helpful. I'm going to hand back to Danielle now as the chair to tell you about our future webinars.
Super, thanks Isobel, and thanks very much Thomas for answering all of those questions in great detail there. That's brilliant. So we've reached the end of our webinar today. Just thank you everyone for attending. We hope you found it interesting and informative and useful for any of the research activities that you're involved in. In a couple of days you'll receive an email with the YouTube link to this video if you want to forward that on to any colleagues or clinicians. It will also contain a link to a feedback form, which we would be grateful if you could complete, just to direct us in the content of our future webinars and how to improve them. We can also issue certificates of attendance for this series, so if that's something that you would like for CPD purposes, please do email us at ppip@psych.ox.ac.uk. Our next webinar, which is listed on the screen there, is going to be on Friday the 10th of July at 10:30 till 11, and it will be presented by Professor Eileen Joyce from UCL. She's going to be speaking on the role of inflammation in first episode psychosis, cognitive impairment. So we hope to see you then, and enjoy the rest of your day.